These are in listen-only mode.
Hello everyone and welcome to tonight's webinar, the 2015 Advances in the Natural Treatment and Management of Small Intestine Bacterial Overgrowth. My name is Emily Sugars and I'm the lab manager here at Sibo Test. I'm the one that receives all your emails and answers all your questions about all things Sibo Test. Tonight's webinar is presented by Dr. Nirala Jacobi. Dr. Jacobi received her doctorate of naturopathic medicine from the esteemed Bastyr University in Seattle, Washington in 1998. 3 years ago, she founded Sibo Test, an online testing provider for the accurate assessment of Sebo. In January of last year, she was invited to take part in a Delphi panel to discuss the developing field of Sebo treatment at the first Sebo Symposium in Portland, Oregon. Nirala herself is considered an expert in the natural treatment of Sebo and has presented on Sebo in past webinars. For some of you, these webinars were the first introduction to the condition. She has just returned from this year's Sebo Symposium, so the webinar promises to be the most cutting-edge information you can get on Sebo. Thanks for joining us tonight, and let me hand you over to Nirala.
All right, thanks, Emily. I am really excited to be here and to be presenting this information to you. In the past year or two, I've really seen an incredible increase in the interest in Sebo, not just from practitioners, but also patients coming in, talking about what they found online, and discussing just some of the blogs and the summits and podcasts and support groups that have really sprouted up over the past year, I believe. Just, one thing is with Sebo, the Facebook group, the Sebo support group in Victoria has over 1,300 members, so there's definitely a lot of interest in Sebo developing out there. And at this year's symposium in Oregon, half of the group, there were about 400 or 500 people, and I'd say about 100 or 200 people in the audience were actually lay people, health coaches and just people blogging about their own condition. And so it's just incredible to me as a practitioner to see how much interest has developed in Sebo. So when people come to see you, they actually tend to be quite educated about Sebo, sometimes much more so than we've ever actually seen before. So that's really exciting. So our mission here at Sibo Test is to not only provide the highest quality in breast testing, but really it's to educate you, the practitioner, and to provide you with resources and handouts and referral brochures and all sorts of things that help you help your patient a lot better. One of the exciting additions to Sibo Test has been the development of individual practitioner pages and finding a Sebo treating practitioner database where people are searching. And we have become a real go-to hub for many, not just practitioners, but patients, and watching the videos and so forth. So it's been really very gratifying to watch that develop and to be there to provide that service. So one of the things I've been saying, just when I'm engaging the interest in people and in practitioners, is this is a great time to position yourself as a natural expert in Sebo, because it is quite a complicated condition. It's not as easy as just treating Candida or some of the more simple things that we treat in our practice. It's really become a lot more defined, and as you'll see tonight, there's a lot of different developments in the field of Sebo. So at this year's symposium, the main presenters were Dr. Alison C. Becker and Dr. Stephen Sandberg-Lewis, who are the directors of the Sebo Center in Portland. That's associated with the National College of Naturopathic Medicine, and also Dr. Melanie Keller. They're all naturopathic physicians and did an excellent job to present some of the developing information. And then Dr. Mark Pimentel, who is the gastroenterologist and director of the Motility Center at the Cedars-Sinai Hospital in LA, and Dr. Lenny Weinstock from St. Louis, I believe, and Dr. Gary Mullins from Johns Hopkins, who actually did the study on herbal antimicrobials in the treatment of Sibo, which I'll present a little bit later on. So the topics covered tonight in this presentation is underlying causes of Sibo, advances in testing and advances in treatment, my clinical tips, what I've come across in the last year and a half since I presented my last webinar, and then we'll take questions and answers later on, hopefully in an hour or so. So this is I think the only review slide of the evening from last year's presentation. So just basically, if you don't know much about Sibo, I really recommend that you review the notes or the slides from last year's webinar, because last year we really went into the nitty-gritty of what is Sibo, how can we, what actually happens on a mucosal level. We're not going to do that tonight. We're going to build on last year. But basically, Sibo is the bacterial overgrowth of normal colonic bacteria into the small intestine. So it's not a condition of pathological overgrowth of pathogens or organisms that cause food poisoning, but really normal colonic bacteria. The cause of the symptoms is basically the damage to the brush border, and therefore the absorptive pathways in terms of long-term Sibo or long-standing Sibo can result in a lot of malabsorption. It's often a consequence of gastroenteritis, and we'll definitely look at that tonight a little bit closer. And 60% of IBS is considered to be Sibo. Now there is, in terms of the academic community, there is a bit of argument around exact numbers, but so far I certainly see that in my practice. Patients that come in with classic IBS symptoms, Rome criteria, specific IBS symptoms, definitely when I test for Sibo, there's a very high prevalence amongst those patients. So Sibo is also a very specific condition which requires proper assessment and treatment. And as I've mentioned, the webinar from last year is available for download for you to review. So Sibo and IBS, I will use those terms interchangeably tonight because of the high prevalence of Sibo in IBS. But the terminology that we use is Sibo D being diarrhea dominant, Sibo M is mixed diarrhea and constipation, so alternating bowel patterns, and Sibo C is more of a constipation dominant pattern, which is mostly methane dominant. One note around more frequent bowel movement and watery stools is that it's unlikely to be Sibo, because typically, even in those people that have a diarrhea dominant pattern, we do see some fluctuations with bowel patterns. So not a very predictive 10 bowel movements every day, watery, and those kinds of presentations do require a little bit further workup in terms of further diagnosis and diagnostic workup. So let's talk about the underlying causes of Sibo, and I think this is so important because oftentimes, and you'll see this also when you do any research into Sibo, you'll find that in terms of conventional medicine, it's become really quite popular to test and then just treat with antibiotics without any further looking deeper into what may have caused it, and also no further instructions on diet or prokinetics. So very often when I see patients that have been referred to me and have had a relapse, for example, that oftentimes it's because it wasn't actually really worked out properly. But one of the things with Sibo is that it can have multiple causes, and when you start to look into those causes, you can sometimes it's easy to treat the underlying cause, and sometimes it's not so easy, such as with adhesions. It's not that easy to treat that. But it's always helpful to know the underlying cause, because then you can also give not just the proper treatment but a proper prognosis in terms of, is this patient to be likely to be relapsing for example, if they have a case of scleroderma, it's unlikely you're going to do or impact a lot of the neurological changes that occur in the digestive tract. And so knowing that would be really helpful, because then certain treatment like prokinetics will be really important for those patients. But the main causes of the underlying causes of Sibo are the impairment of the migrating motor complex. We've discussed that last time, but just briefly, the migrating motor complex is a neurological event that occurs in the small intestine in order to sweep out the contents of the small intestine. So it's a normal occurrence that ensures that we don't have residual bacterial overgrowth in the small intestine. And when that's impaired, it's just like a river that stops flowing. It'll become stagnant. And so those underlying conditions usually have something to do with affecting the enteric nervous system. Sometimes anatomical issues cause the normal loops of the small intestine to become a bit kinked, like a garden hose. So when that happens, you have upstream pressure and upstream stagnation and overgrowth of bacteria. By far, the most common cause of Sibo is a post-infectious picture. So this is somebody who went traveling or had a very memorable case of food poisoning that shortly thereafter, it may not have been right, the day after they got over the food poisoning, but maybe within a few weeks or months they developed IBS-like symptoms, and that's a very classic presentation. Diabetic enteropathy, also very common, especially diabetics that suffer from gastroparesis or slowed gastric emptying. Adhesions are basically your body's or the body's way of healing as an injury. So it's an intra-abdominal scar tissue that forms post-surgery, especially after an appendectomy, endometriosis with laparoscopies, a cesarean cholecystectomy, or the removal of the gallbladder. So those are very standard procedures that patients come in with and don't ever think twice about it. But if they have Sibo, those history events are really important, and to be able to assess them for adhesions. And we'll talk about that a little bit later on. Blind loops, that's more important or more relevant to gastric bypass patients. Something called pseudo-obstruction, which is a mechanical obstruction without evidence of anatomical obstruction, and that's basically what I've described, the kink in the garden hose, and there are different reasons for that. Medications such as narcotics, like morphine, codeine, illicit drugs, or proton pump inhibitors as well. And that's not an exhaustive list. There's quite a number of medications that can affect the migrating motor complex. And people that come in with chronic pain management that are very reliant on medication, that's a very common occurrence, actually. Stress, this is a bit of a contentious issue, because what we now know about Sibo is that stress doesn't cause Sibo, but stress can affect the output of hydrochloric acid and the motility of the small intestine. So you can have a resulting bacterial overgrowth from stress, but if it doesn't affect the migrating motor complex to a great extent, those are usually self-correcting. Large and small intestinal diverticulosis, so little outpocketings and bacterial growth that occurs in these little pockets. It can also be an underlying cause of Sibo. Alcoholism, again affecting the migrating motor complex, as well as other disease states like celiac disease, non-alcoholic steatohepatitis or fatty liver, and pancreatic exocrine insufficiency, so not enough output of digestive enzymes. Let's talk about post-infectious Sibo. This was a really interesting presentation by Dr. Pimentel, who talked about the military study that looked at the likelihood of developing IBS after stressful events. So this goes back to the question, is IBS or Sibo caused by stress? And by stress, they included what I would consider quite traumatic events, such as shooting a gun in combat, shooting another human being, active combat, and being injured in combat. And And what they found is that only a case of gastroenteritis was associated with the development of IBS. So none of the other events triggered Sibo. They may have worsened it, but it's usually not a triggering or a causative factor when we talk about stress. So risk of post-infectious IBS increases 7-fold after infectious gastroenteritis. So what that means is Sibo, those soldiers that had gastroenteritis, or your patient that had a food poisoning and is now quite stressed, or maybe not stressed, but in any case, if they had food poisoning, it usually increases their risk of developing Sibo by 7-fold, which is quite a dramatic increase. The 4 main infectious organisms that cause acute food poisoning are Campylobacter jejuni, E. coli, Salmonella, and Shigella. Now, just a note on those are not the 4 organisms that I've mentioned in my last lecture or webinar that are your main prevalent bacteria of normal flora that we find in cases of Sibo. So those 4 organisms that I've just mentioned, the Shigella, the E. coli, the Salmonella, and the Campylobacter, they all secrete a similar toxin called cytolethal distending toxin B, quite a mouthful. And what the body does in response to this toxin that's secreted by the bacteria is to secrete an antibody to the toxin. This antibody, anti-CDTB, is similar to vinculin, which is a very important component of the migrating motor complex and the enteric nervous system. This is sort of like a case of mistaken identity, where the anti-vinculin antibodies are made instead of the anti-CDTB toxin. And anti-vinculin antibodies then consequently attack the enteric nervous system. So this is more in a visual, where we have a case of food poisoning. Those are the 4 bacteria that cause the food poisoning. They secrete a similar toxin. The body then creates antibody to the toxin. It mistakes anti-vinculin, and we have a case of autoimmunity, which results in gut nerve damage, which reduces ICC. And ICC are interstitial cells of Cajal, which are the target of the migrating motor complex. And therefore, you have a reduced cleansing wave or migrating motor complex after a case of gastroenteritis, which then results in Sibo. So here's a picture of the ileal interstitial cells of Cajal, which are, again, part of the migrating motor complex. And what they do, it's really interesting because the vinculin is a component of the migrating motor complex as well, and the ICC are involved in all of that. And what they do is they pull cells a little bit closer together. So we understand zonulin and occludin and all these other components that zip the cells together. But what happens with the ICC cells, they're actually, and vinculin is a little fibril that actually pulls cells closer together. So not the zipping part, but anyways, that's not really that important. But I just wanted to, I'm fascinated by these, by those little microscopic events. So those are the cells that are pointed out in these arrows. And what happens after a case of gastroenteritis or food poisoning, and especially multiple courses or multiple events of food poisoning, is what we see is very, very diminished cell or ICCs in the migrating motor complex, resulting in a very impaired cleansing wave. Nerve inflammation is also the driving force of autoimmunity, and what we know is that if inflammation occurs without this development of anti-CDTB and anti-vinculin antibodies, those cells are actually very capable of repairing within a very short period of time. So it's that autoimmune component that becomes very important when we're talking about resolving Sibo and management of Sibo. In patients with a history of food poisoning and irritable bowel syndrome, those patients that have had that have Sibo, they are 5 times more likely to get another episode of food poisoning due to this slowed migrating motor complex. And it takes, with every case, it takes fewer and fewer bacteria in each episode to cause food poisoning. And each episode, therefore, also increases the likelihood of developing Sibo due to the further decrease in motility. The big question then becomes, for any practitioner treating Sibo, is in cases of post-infectious Sibo that's really well established. And in my practice, I have I ask very specific questions about have they ever had food poisoning? Do they remember having the food poisoning? Because a lot of people have it, but they don't necessarily remember. And most of the time, people that have Sibo will remember very clearly an event that happened whilst traveling, for example. But the big question is, in those cases that are very clearly linked to post-infection, should our main goal really be the resetting and repair of the migrating motor complex rather than just primarily focusing on antimicrobials? And there's good evidence to suggest that after even just a brief course of antimicrobials, moving on to prokinetics is quite successful in continuing to improve the cleansing wave and improving test results. So what I do and have started to recommend to my patients that have an imminent overseas travel or are more prone to getting food poisoning is to have some sort of preventative strategy. And I use my herbal bitters that I've mentioned in my last webinar, but also the new developments or the new presentations done by Dr. Seebecker at this symposium, where made a strong case for Iberogast, and a lot of you will know that. It's a very well-known herbal remedy available at health food stores and chemists and so forth. And that seems to be a really helpful addition to the treatment plan. I use antimicrobials for prevention that they take every day, and you want something that contains berberine, and whether that's berberine 500 or Bactrex or the number of berberine containing products out there. Again, this is not for treating Sibo, but more as a preventative strategy for my traveling patients. And I always like to use Saccharomyces boulardii because of the evidence for C. difficile prevention and treatment. Another underlying cause, as mentioned before, is adhesions, and this was a very interesting talk by one of the physical therapists at the symposium, and how to treat adhesions. It's beyond the scope of this webinar to really go into the very specifics of what he talked about, simply because it's an actual in-person presentation. But basically, adhesions are really, really common, and I do abdominal exams on my patient, and you can really palpate, especially with endometriosis. You can see the rigidity and the immobility of the organ. So I would recommend that you become very proficient in your abdominal exam skills, and even just feeling for restrictions and for adhesions is just so helpful and affirming for your patient. But again, as I've mentioned, there are lots of different abdominal procedures that can cause these adhesions. This was Clear Passage is the organization or the center that specializes in the non-surgical treatment of adhesions. I'll put the website there. And what they do is they do 20 hours of treatment over 5 days, which is 2 hours in the morning and 2 hours in the evening, for a total of 20 hours. And they do a series of cross-frictional treatments and very specific physical therapy to break up adhesions, and quite compelling, I must add. They had a few patients that attested to the effectiveness of this treatment. But of course, I always think I'm not going to send my patient all the way over to, I think they're in Colorado. I'm not going to do that. It's very impractical. I'm going to start looking into other possibilities of visceral release and acupuncture and so forth. I think that's a big, it has actually quite a bit of potential, because if we're talking about a kink in the garden hose, we need to be able to treat that for really long-term resolution of Sibo, or if if that's not happening, then they'll never really resolve that issue for them. So I think the treatment of adhesions might actually be more important than we think. I get a lot of questions about castor oil. I love castor oil packs, but I just really don't think that they alone will do the job. So it's always nice and comforting to have a hot pack on your abdomen, but I just don't think long-term use of that is going to break up these adhesions. Okay, let's talk about developments in testing for Sibo. There is a new blood test for IBS, which does not replace the breath test. There's again, lactulose and glucose breath test. Not much has changed in terms of how we assess for Sibo, but our reference ranges have changed based on the latest criteria and consensus at the Symposium. And then we'll also talk about a few other tests to consider for your Sibo patient. So the new IBS blood test, which literally just released. I just came back last Wednesday, and so I think it had just been released 2 weeks prior, so it's absolutely hot off the press. It measures anti-CDTB and antivinculin antibodies. It's about 60% accurate in diagnosing IBS, and so what that means is Dr. Pimentel developed this test, and his intention was to not have this test be the replacement of breath tests because of reasons we'll see in a moment, but really to prevent further sort of extensive workup by, in terms of colonoscopies and endoscopies and barium swallows and whatnot, done by gastroenterologists to assess IBS. So if the patient tests positive, what we then know is that yes, indeed, this patient has had an exposure that was significant enough to the bacterial toxin that most likely has affected his or her migrating motor complex. Again, this does not replace the lactulose breath test because we still don't know if this patient has Sibo or not. But if you then test positive on a breath test, that basically seals the deal in terms of that this patient definitely has autoimmune IBS. And I think this will be a pretty significant test for a lot of people that have suffered for a long time to have some sort of understanding as to what's happening in their body. Now, the drawbacks of the blood test is that if it's negative, you can still have Sibo because it's not 100% accurate. But it means if it's negative, it's less likely to be caused by an autoimmune reaction, so they can still have these other underlying issues like the diabetic enteropathy or many of these other issues that we've mentioned before. You need to follow this up with a breath test to confirm that they actually have Sibo. The problem is that it's not yet offered in Australia. I've talked to the lab, it's Commonwealth Lab in America, and the thing is that until I actually know for sure that because I need to receive the blood in 48 hours, until I myself have tried it out with a few patients, I cannot publicly endorse this test as of yet. But they will be offering it in Australia with a courier system, and I will test that out and will report back to you. But it does offer quite an exciting new avenue for us as practitioners. Let's talk about the lactulose breath test again. It's still considered to be the primary test for Sibo in the wider Sibo community. Sibo test uses the same guidelines and reference ranges as the Sibo Center in Portland. We do a 3-hour breath test where the first 2 hours are considered small intestinal time, and the last hour is considered either slow transit or large intestinal time. We are the only lab that offers the lactulose breath test in Australia. The lactulose breath test only. Most other labs require lactulose and glucose. Why are we testing? We need to understand the levels of hydrogen and methane. And that's important to understand what guidelines you need to give your patients as far as how many cycles of antimicrobials, when will you start your prokinetic, and so it becomes really important to monitor those types of the levels of hydrogen and methane. You retest to ensure the bacteria are eradicated before you start your prokinetic therapy. So this is just a series. The next 3 slides are the same patient that I started treating in June. This is just a demonstration of testing and retesting and why you would continue with your treatment. So this patient came to me, she's in her 60s, she came to me with the primary complaint of reflux and bloating. We did a test, and as you can see, at the 100th minute, we see a level of 34, which is pretty positive. Even at 80 minutes at 23 and at 60 at 25, we're talking hydrogen here. Those are all positive levels and quite high levels of methane. Now, it's normal. Some people that are asymptomatic, if you tested a random person, a lot of people are methane producers. It doesn't necessarily mean that they do have Sibo, but it becomes more like the diagnosis of Sibo becomes more important if they have a complaint of constipation and high methane levels, which she did have. And so the important gas to measure in terms of diagnosis of Sibo is that I think the hydrogen is slightly more important when we look at that. Then we kind of treated her for a couple of months. She had to travel a little bit, so we didn't retest straight away. We did that in November. And her hydrogen was then completely normal, which was great, but her methane was greatly reduced. I used Alimax. I used just some healing herbs for her gastritis, and I also tested her for H. pylori, again, a stool test that was negative, that had always been negative, just to ensure that there wasn't any underlying other cause of inflammation. So her methane really responded well as well, but still quite high, and still positive because she had this initial complaint of constipation and reflux. And just recent results we've done also in May. Once again, she was traveling. She does a lot of traveling. So we tested when she stayed on the maintenance diet the entire time, and her methane is still slightly high, but definitely far, far better. So this is a good example of why you would test, because for all intents and purposes, you'd be thinking, okay, this is almost a year into treatment. I don't have to retest this. The patient at this point is asymptomatic, but she wants to get her methane down to a level of 3 because that's the recommended level from Dr. Pimentel. So that's what we're shooting for. So she's continuing on the protocol. I expect that I will introduce, we actually did try the bitters, my herbal bitter formula, and that was just way too reactive. She had reflux quite quickly after introducing the bitters, so I stopped that. But I will try the Iberogast, which we'll talk about in a minute, as a prokinetic after this next round of antimicrobials. So let's talk about methane for a moment. Again, it's basically one organism, not really a bacteria, known as Methanobrevibacter smithii. It's really the sole organism that produces methane in the human body. It's also known in other research as an obesogen, actually, because it is so effective in extracting calories from the food. So we don't really know if there's any other benefit, but we know that people in sub-Saharan Africa have higher levels of this organism, and that may have been an evolutionary advantage if you are able to extract calories from foods a lot more effectively. But the sort of not very beneficial effect of Methanobrevibacter smithii is the fact that very high levels of methane are very much linked to constipation. So what we often see are cases where methane is very high, patient has been constipated for many years, and by reducing methane overall, we do see quite an improvement in their symptoms. Dr. Pimentel says that this is part of the new guidelines, is that we need to get methane down to below 3 parts per million, which is where when people are complaining of constipation, they do feel the best. Methane is poorly absorbed from the large intestine, so when we see methane high throughout, we can imagine that they have methanogens not just in the small intestine, also the large intestine, but we do typically assess that more in the small intestine on the breath test results. We don't actually see a methane rise with lactulose. This is just a little tidbit of information. And so what we will see, or what we will try to develop in the next few months, is a spot retest, where if you know your patient is a methane producer, we might just be able to do a one-time breath test without a prep diet, if they're still on a maintenance diet, without a substrate like lactulose, and just a very quick sample to see where you're at, and that's going to be a lot more cost effective for your patient. So I'm really excited about that, and if you're on our mailing list, you will definitely will be updated with the Sibo news as to when that's coming out. So what do you do if your lactulose breath test is negative? One thing is, no test is perfect. If you are suspecting Sibo is happening because your patient fits all the criteria, I think that it's still prudent to proceed with treatment. You can also consider a glucose test. As mentioned in last year's webinar, glucose tends to be absorbed very rapidly from the proximal the proximal small intestine, which is the first part of your small intestine. So very often it does miss the Sibo that's present later on in the small intestine. But it's certainly a good practice if you do get a test result that's negative and the patient is disappointed, you can suggest that they do a glucose test to confirm that result. Other tests to consider for your Sibo patient, these are not diagnostic of Sibo but tend to be helpful. If you see that your patient is not responding quite as rapidly as you expected, a lot of people that initially present with Sibo have very similar symptoms to people that present with celiac or gluten intolerance. Although when we start treating for Sibo, it is by definition a gluten-free diet. But people that have been on a gluten-free diet, for example, and are not improving, are very often have an underlying Sibo picture. So they'll have gluten intolerance, but they'll also have Sibo. I sometimes do a complete digestive stool analysis and look for calprotectin, elastase, and fat in the stool. So calprotectin is a marker for gut inflammation, and it's usually used to differentiate your irritable bowel patients from your inflammatory bowel disease patients. And it's actually they monitor disease progression. So that's sometimes obviously a big clue. If your calprotectin is high and your patient is still symptomatic, you probably will need to refer for that. Elastase is a marker for pancreatic efficiency and output of exocrine digestive enzymes. So if elastase is very low and patient is still symptomatic, you know you're going to have to put in a digestive enzyme formula. Fat in the stool, this is a really interesting one because fat in the stool means that, or steatorrhea, means that either, and let's say they have fat in the stool and the elastase is normal, you would not suspect that it's due to pancreatic insufficiency, but it's very possible that they have bile acid deconjugation from Sibo. So I started to use that as a sort of, not a diagnostic tool, but an indirect marker for Sibo. Food sensitivities, it's always very helpful. I've just had, unfortunately, I had to do this on a patient just recently, and she was still quite symptomatic. Turns out she was just through the roof sensitive to coconut, which is of course quite disappointing when you're on the Sibo diet because we use coconut flours and coconut oils and different, all things coconut. Coconut cream is often very, very not negotiable from a lot of people that have limited a lot of their foods. Also, I do a lot of MTHFR testing and other methylation tests because some people are quite sensitive to histamine, and as we know, with methylation defects or deficiencies, we do see problems with clearing histamine in some patients. As you know, just an MTHFR, we're not able, if you know that your patient is homozygous or heterozygous for either 1298 or C677. That doesn't really tell us downstream methylation defects, but it does tell us that the patient may have a propensity towards difficulty with clearing histamine. And these patients also will need to have more B12 and active folate, and that's because when patients have Sibo, their B12 and folic acid status is really compromised because bacteria really deplete deplete the status and also prevent absorption of those two nutrients. And then we had also a very interesting presentation by a gastroenterologist in California who treats primarily Lyme disease, and really made quite a compelling case that sometimes when you have a patient with ongoing symptoms, you've treated them for Sibo, they're tested positive, and they're not, and test is then negative, but they still have symptoms. That should be maybe part of your differential diagnosis if the picture fits for those types of stealth infections. The alarm symptoms, signs and symptoms in irritable bowel syndrome that require, and Sibo, that require more extensive evaluation, such as imaging studies or colonoscopies, are fever, weight loss, obviously blood in the stool, although sometimes when somebody is quite constipated and has fresh blood on toilet paper and they have hemorrhoids, it's likely to be that. But if they actually have blood in the stool, this is not a good sign. Nocturnal symptoms are symptoms that happen at night, like abdominal pain, and also progressive abdominal pain, and certain laboratory abnormalities such as calprotectin, higher CRP, perhaps higher ferritin, and higher ESR or erythrocyte sedimentation rate. So those inflammatory markers that you're looking for, you do need to consider that that this may be beyond what you can deal with, and you might have to refer this patient. So advances in treatment are the, we're going to talk a little bit more about rifaximin, herbal antimicrobials, and finally the elemental diet, which I have been resisting for 3 years, but I will definitely get more into it this next year. A very compelling presentation by Dr. Seebecker, and so we'll talk about the homemade elemental diet, and we'll talk about prokinetics a little bit more. The conventional prokinetics are low-dose erythromycin, LDN or low-dose naltrexone, and prucalopride, which is Resolor. And the herbal antimicrobial, prokinetics are Iberogast, Silmotil Pro, and ginger. So this is a really quick and dirty look at what the typical treatment flow is. So you've tested your patient, they're positive on a breath test, you're going to start with antimicrobials and the Sibo diet. You typically, depending on gas levels, so let's say they had gas levels in 60 or 80s of hydrogen. Hydrogen, as I've mentioned in my last webinar, is not as predictive. So if you have very high levels of hydrogen, we can't predict the patient needs X amount of treatment round, but with high methane, that's fairly predictive. If a patient has, for example, a methane of 60, you can expect to do 2 to 3 treatment rounds, each one being the herbal antimicrobials. You're looking at about 4 to 6 weeks of treatment. So let's say that they're positive, you've done all that, you're going to retest in 6 to 8 weeks. If they're still positive, you're going to repeat what's happening above, and if they're negative, great, you've done a fantastic job. You move to maintenance phase, and the maintenance phase is the maintenance diet, which you can download from the practitioner section in the on Sibo test if you signed up for that service, free, and you'd also use prokinetics. So the antimicrobials, rifaximin is by far the biggest star in the Sibo antibiotic regimen. And other antibiotics are also used. I still, as a naturopathic doctor, have my comfort level with prescribing antibiotics, just like multiple courses, is just not very high. But Dr. Pimentel talked extensively about rifaximin, which I'll give you some pointers around that. And for those of you who can prescribe, apparently Kingsway Pharmacy rifaximin has just been actually approved by the FDA in America, so we do expect that the price to go down, and that was the biggest resistant patients had to actually getting rifaximin prescriptions, but I think the compounding pharmacy in Sydney that people are getting their rifaximin from is quite reasonable. We're also going to talk about herbal antimicrobials and the elemental diet. So Xifaxan, which is rifaximin, it's very, very indicated for high hydrogen levels. And rifaximin and neomycin are used for high methane producers. Rifaximin does not cause dysbiosis, and they've proven that with deep sequencing before and after rifaximin, and they found 98% that the microbiome was 98% the same before and after rifaximin. So it doesn't cause dysbiosis because it is a bile-soluble antibiotic and not water-soluble. And what that means is that it's water-soluble antibiotics that cause such rampant die-off and microbiome disruption. So we don't typically see that with rifaximin. It doesn't also cause antibiotic resistance, which is great. So which means that each course of rifaximin tends to be as effective as the first. When you combine rifaximin with other antibiotics like neomycin, those other antibiotics are less likely to cause bacterial resistance. So that's also good news. Again, I cannot prescribe antibiotics. I'm giving you this information because A, patients are coming in demanding either this prescription or you are a GP and you can prescribe them. So a great resource for you then is SiboInfo.com. This is Dr. Seebecker's site, and she has very specific antibiotic prescribing regimens. The dose of rifaximin is 550 milligrams 3 times daily. Very, very important to keep very tight schedule. The compounded rifaximin, there is a bit of an argument around compounded product because some of the suppliers are quite unreliable and there's some question about efficacy. But I think this is going to be a moot point in the future because with FDA approval, we're going to see the price drop pretty substantially. I've had a couple of patients actually who did get rifaximin and did have very good results, but they did have long-standing disease with underlying issues that were unresolvable in terms of we needed to keep them on a prokinetic and do different rounds of rifaximin, and that seemed to work well for them. Herbal antimicrobials, I'll just briefly mention Dr. Mullen's research at Johns Hopkins who showed herbal antimicrobials as effective as rifaximin, so that was very promising. But one of the issues with herbals is that it does take longer. Each course will take about 4 to 6 weeks. So in some patients we'll be totally fine with that, and some patients will opt for something quicker. But Dr. Mullen's research used 4 products from one US company, it's Biotics Research, and none of them were actually specifically formulated for Sebo. And this is just for your information. You can look at that at your leisure, and those are the 4 products and their contents. And he found this very useful. I don't think he used them all together in each patient. He assessed each patient individually. So the tried and proven herbal antimicrobials that I use every day in my practice are berberine, and I use either berberine 500 from Thorne, and I have my patient order that from FX Med. Neem as well from Ayush is the formula I use, and I don't use it as often. I also use Bactrex from Metagenics, and I sometimes make up my own tinctures depending on what else the patient presents with. The thing with berberine is you need to go up fairly high, about 2,000 milligrams to 3,000. Actually 2,000 to 5,000 milligrams daily, and that becomes sometimes very difficult for the patient. They become sometimes very nauseous with that, and so it's a bit of a trick to get the dose right. But I like Metagenics Bactrex. It's pretty good. And just as a disclaimer, I don't have any financial interest in any of these companies. I'm just a practitioner sharing what it really has worked quite well for me. Oil of oregano is also fun, like with MediHerb, Bactrocand, and so forth. For methane producers, we still use Alimax from Biomedica. You can get that from your distributor. I usually use NRG or somebody like that. And oil of oregano as well as neem. And the protocol for those antimicrobials is still in the resource section on Sibo test. The potential new antimicrobials that I'm researching right now and will hopefully have sort of an in-clinic based research over the next year will be Manuka, pomegranate, and horopito. And I'm sure that there are others that we could include in that list. I've looked into pawpaw leaf and different kinds of really interesting herbs. So stay tuned for those results. Interesting is also the concomitant infection of fungal or co-infection. When you have Sibo, very likely or very often we also see small intestinal fungal overgrowth, and that is luckily very easily treatable with the very prescriptions that I've just gone through, the herbal antimicrobials, especially things like Bactrax and oil of oregano. We're well versed in that in terms of how to treat fungal overgrowth. The diet and the antimicrobials treat this well, but you might want to add in additional antifungals and probiotics. We're actually not, there's a few things that we don't really use as much anymore, and that's probiotics whilst treating and biofilm penetrators. But biofilm penetrators or disruptors are very successful with fungal overgrowth, so I still use it occasionally, and we've had sort of mixed reports from practitioners that either get fantastic results from using biofilm penetrators or none at all in terms of test and retest results. So I will leave that up to you, but I've sort of dropped some of that simply because it's just so many different products that patients are taking, so it's case by case. Elemental diet. So it's probably the most effective treatment you can give your patient for Sibo. It can reduce gases from up to 120 parts per million in 2 weeks, which is amazing, and we've had a few reports of even higher than that, up to 148 parts per million. But it's probably the most effective. I have not personally prescribed it to my patients yet, partially because I have not been able to source the amino acid products that you need for that, which we'll go through in a minute. But I think we will have an answer for that very shortly, and I'm in the process of sourcing a good source of that. So the elemental diet is considered not a diet. Actually, it's considered an antimicrobial treatment. So it's a 2-week protocol, and it was first talked about by Dr. Pimentel, who used Vivanex. And Vivanex is a meal replacement formula, tastes horrible, quite processed. And so to solve that problem, Dr. Siebecker has come up with a homemade elemental diet recipe, which you can find on her site, but we'll go through in a minute. And this has not been formally tested, but Dr. Siebecker reports very excellent results with this. What it contains is amino acids. So these are not the whey protein powders or the detox protein powders that we often prescribe for our patients. These are just pure amino acids, and typically they taste horrible, and because you have sulfur-containing amino acids, etc. And by far the most frequent complaint about them is taste. The carbohydrate content will be added to in the form of either honey. I would even use something like maple syrup because it's very low FODMAP, or glucose in the form of dextrose. So in a few weeks I'll probably have, I'll send an email around once I have confirmed the source of the amino acid product. You also will need to use some micronutrients like a multivitamin, but I wouldn't put it into the formula. You would just use it in addition, as well as some electrolytes. There are 2 versions, which we don't really have to talk about because we're only going to talk about the homemade elemental diet. So the homemade elemental diet is not as expensive. It's around $200 versus more like $600 or $800 for Vivanex. So this usually cinches the case for many people. Vivanex has been studied. It has shown excellent results with Sibo. The homemade one has not been studied, but it contains cleaner ingredients, no soy, maltodextrin, or preservatives, and it's separate ingredients that have to be mixed together versus pre-mixed packets for the Vivinex. Both Vivinex and homemade are actually very, very good for hydrogen and methane. The challenges are the bad taste. It's very emotionally difficult to be only consuming these 3 serves of the elemental diet for 2 weeks. So it's definitely difficult for a lot of people. So it's hard to start with, and the last 3 days are almost impossible. I'm not trying to dissuade you from doing it. I will definitely try to talk my patients into it because it sounds like an incredible treatment, and some of the presentations were very convincing. We do see quite a bit of die-off, so you'll have to warn your patients about that, especially in the first few days, and that can result in weight loss. So I wouldn't necessarily think of that for your very thin patients that easily lose weight. And it can also aggravate yeast, but this can be because typically Vivinex is surprisingly high in dextrose, and if you drink that, you just can get oral thrush, and you can have a small intestine fungal overgrowth aggravation, but that's typically not, it only lasts for a few days. So the ingredients, again, are an amino acid blend of about 24 grams of protein per serve, and that's 3 times a day. And dextrose at about 100 grams of carbohydrate per serve, but this can be adjusted. And then you also add some oil to that. It's based on a 2,000 calorie diet per day. And some of the clinical notes from Dr. Siebecker is that it's really recommended that friends and family don't undermine the patient and give encouragement. And obviously, you don't want big events happening, weddings or going out or any of that, because it makes it really difficult. You can expect some bowel changes, some odd colors. You might have a bit of diarrhea or constipation, and it can take 1 to 2 weeks for stools to normalize after, or a little bit longer. So you can have all sorts of things happen on this diet, as I can imagine you'll not just have die-off of Sibo, but probably also some large intestinal die-off. You can have flu-like symptoms, fatigue, headaches. Doesn't sound like a lot of fun, but these are just notes to not be alarmed by these side effects, and it certainly doesn't happen in every patient. Some important points, as I've already mentioned, you cannot use your whey proteins or your rice-based proteins or any of the ones that are on the market. It has to be a very specific amino acid formula. And you also want to wait about 10 days after completing the elemental diet before retesting, although Dr. Pimentel did talk about after 14 days retesting, and if it was still there, just adding on another week as just to ensure that bacteria are completely eradicated. So you can do that as well. Again, as a reminder, you do not need to use any antimicrobials, anything else additional to what I've just listed for the 2 weeks. So it is a really effective treatment for those 2 weeks. Okay, let's talk about prokinetics. I used to use prokinetics pretty much straight away, especially in my constipated patients, but now I start them after the completion of the antimicrobials and when the retest is clear, just so that it's a very delineated form or staggered program, so that it's not too overwhelming initially. Prokinetics aim to reset the migrating motor complex, so it's not just a case of giving your patient a laxative, but it's really about jump-starting that cleansing wave. Failure to use the effective prokinetic protocol is definitely a very common cause of relapse, and certainly one reason why I see patients in my clinic that have been referred. The prokinetics that were discussed at the symposium is a new one which is available, and it's so new that I don't even know if it's available in Australia. I'm sorry about that, but it's available in Canada and in Europe, and it's very effective prokinetic. And some of the research and into prokinetics has been very abysmal, and a lot of prokinetics have actually been pulled off the market because of their side effects. And according to Dr. Pimentel, this one is not a is a prokinetic that's not associated with many side effects at all. Also low-dose erythromycin and low-dose naltrexone, which we won't really talk about here. And then the natural, which is iberogast, ginger, and Modal Pro. So I'll have you read about prucalopride. It's a 5-H24 agonist, which is basically the precursor to serotonin. Serotonin is a very effective agonist for propulsion through your digestive tract. And low-dose erythromycin. This is something that's interesting because it's a 50 milligram dose, which is not considered to be actually an antibiotic dose at all. It's a motilin agonist. It works on the stomach and the small intestine. And in vitro, meaning in a petri dish, there's no effect on the microbiome. But we don't have any in vivo proof of that. So we don't know. In my opinion, I am still a little bit reticent to use that, but I have used or have requested patients get a prescription for that for when nothing else has worked. So it's just a good thing to have up your sleeve, and definitely in those patients that I use or recommend low-dose erythromycin for, I would definitely consider a probiotic. LDN is low-dose naltrexone, and if your patient does end up having an autoimmune case of Sibo, then I think there's more argument to be made for low-dose naltrexone because it's often used in that context, not just for Sibo, but for other autoimmune conditions. But there are really mixed results, so I didn't really want to get into it here. But if you do need more information, please email us, and I will certainly give you more on that. So the herbal prokinetic that's kind of come on the scene now is iberogast, which is the humble little iberogast that sits on every shelf in a health food store and chemist, and surprisingly has actually quite a lot of studies associated with it. We see 40 years of clinical use for nausea, gastroesophageal reflux disease, bloating, cramping, pain, constipation, and diarrhea. It's a 9 herb combination herbal with really interesting herbs that I wouldn't think can have the power to do all of that. But there are over 47 articles that show the effectiveness of iberogast, especially in the case of not just dyspepsia but gastroparesis, which is slowed gastric emptying. And in many cases, there is such an underlying issue with the enteric nervous system with that. So that was really good to see. There were 5 review papers, there were 4 meta-analyses, 6 randomized clinical trials, 5 other types of studies, and so really quite impressive array of articles written by or written about a herbal remedy, which we really don't see very much in research. So I will definitely be using that as a good alternative to some of the other prokinetics. Or we really don't have that many herbal prokinetics, so we really need to actually get a little bit more clinical research on this. But so far, I welcome every new addition to our armamentarium that has it, especially if it has research. It does, however, does not have any studies into Sebo, but looking at the array there, I can see that it definitely has potential to work. I will leave you with these studies and safety record, etc., on iberogast. Just a few words on ginger. It's interesting. It's always so nice to have a validation in research for the effectiveness of ginger when we know we've always used it for nausea, and it's nice to actually get a mechanism of action for that. But ginger does modulate serotonin signaling. It also promotes gastric emptying, which is really fantastic, and also increases motility rate. Again, a little bit more studies on the motility effect, and there was even a few, like one practitioner who talked about using the ginger chews, which are covered in sugar, but she actually had very good results with even just a ginger chews in terms of gastric emptying. And anyways, I wouldn't recommend that, but it's just a testament to the effectiveness of ginger. Modal Pro is the product that I'd recommend it. It's by Pure Encapsulation, and again, you can have your patient have that order from FX Med in New Zealand. And it has, it's an array of different nutrients, especially B6 or pyridoxal 5-phosphate. That's a cofactor to actually decarboxylate 5-HTP into serotonin, so we can see why that would work. Ginger, as we just mentioned, at 1,000 milligrams, and definitely 1,000 milligrams can cause a little bit of burning, so you might actually need to tailor that a little bit. What I usually do with Modal Pro is have people take 3 in the morning and 3 right before bed, and if that's too strong for them, they start with 2 and 2 and work themselves up. Acetyl L-carnitine is also in this formula, and that's for the synthesis of acetylcholine, which is another agent that helps with motility in the digestive tract, or another neurotransmitter. 5-HTP, as mentioned, is used for serotonin production and also to stimulate enteric neurons through the activation of those 5-HTP receptors. One big bummer for me is that it does contain ascorbyl palmitate, which is a palm oil derivative, and I really don't like that personally. But we have, like I said, such few things in our armamentarium. I'm willing to overlook that at this point. Some thoughts on prokinetics. Your patient needs to stay on it for a minimum of 6 months, even if symptoms have resolved. Now, if somebody has a case of autoimmune Sibo, where they have elevated anti-vinculin antibodies and anti-CDTB antibodies, you might want to consider that they stay on Iberogast. I mean, it's not a difficult thing. Iberogast is typically dosed at 20 drops 2-3 times a day before meals, and you do want to use the prokinetic, the last dose at night, so right before they go to bed, because that gives that exposure overnight to this prokinetic agent. So what I usually do is when I'm done with the patient, I stop the prokinetic, I do retest to ensure, after a few weeks, to ensure that the migrating motor complex is definitely working. And in cases of debilitating adhesions or more severe disease, patient may have to stay on it indefinitely. Okay, we're getting to my clinical tips before we head into question time. So one of the things that I've noticed, certainly in the past year, since I'm seeing so many more Sibo patients, is that patients are often super sensitive, and I'm sure you can attest to that the patients that you're seeing are on a bag full of products. They come to you, they're salicylate sensitive, they can't do this, they can't do that, oxalates, they histamines, all of that. And sometimes it is because of the brush border that's just been very, very disrupted. When that has happened, we do often see a histamine intolerance because the microvilli and the brush border are at the site of diamine oxidase production, which is an enzyme that does break down foodborne histamine. Often they're very salicylate sensitive and sulfite sensitive. I put this slide in there because, and I highlighted all the different symptoms that can be related to Sibo. And that is nausea, stomach aches, food allergies, loose stools, and I would add bloating to that for sure. I don't know why I didn't put that on there, but that should be on there as well. But these are all symptoms that can be related to histamine intolerance. And typically, the patient also has seasonal allergy, so they really present with this higher IgE level or picture. But motion sickness, car sickness, seasickness, all kinds of nausea-related symptoms. And I'll make this list here for you. Foods high in histamine, any fermented food. So those people that cannot tolerate homemade fermented foods, kombucha, sauerkraut, that's often a big clue. Also, all tin products, especially tinned fish, and unfortunately, spinach, eggplant, tomato, and avocado, all of the foods, these foods are actually allowed on a Sibo diet, and that's, I guess, why I'm also pointing it out, that sometimes people still react to those foods. The rest you can look through at your leisure. So, and products to consider for your very sensitive client, generally speaking, L-glutamine, of course, is going to be so helpful to help to heal the microvilli, although if Sibo is the only concern that you pay, a very straightforward case of Sibo, and you kill bacteria, the body usually heals leaky gut within a short period of time. But for those that are super sensitive, I usually add a little bit of L-glutamine, some digestive enzymes, which include brush border enzymes, and I still use critical digestion from Enzymedica. You can get that also from FXmed. Your probiotics, those patients tend to need a little bit more either LGG or Lactobacillus rhamnosus. Those kinds of immune modulating probiotics sometimes are very helpful for them. And if they have a histamine sensitivity, there is a product out that is, I believe it's a bovine source of diamine oxidase, and that can be effective. It's quite expensive, and they would use that with foods. One thing I didn't mention about the histamine foods, all foods, especially protein-containing foods, will develop histamine the longer they sit. So that's why leftovers, even though we love people home cooking and preparing all their meals, but if they are sensitive to histamine, it's advisable to counsel your patients on minimizing leftovers because they will develop histamine in their foods. Also vitamin C and B6 and copper. All those nutrients are important for clearance of histamine. For salicylate sensitivities, I usually use glycine. I use Dr. Vera's. I just put, companies willy-nilly. I list them in my presentation, but again, I have no financial ties at all to those companies. Sulfite sensitivity, I use molybdenum as it helps with clearance of sulfate through phase 2. Okay, let's talk about constipation. By far the most difficult thing when somebody comes in with high methane levels, they have been constipated for many months, sometimes years, and even though you're reducing your methane, something is still not moving. So I've kind of developed a little program which we'll go into, but the Sibo diet itself can be very constipating because if you have a diet that's very high in protein and in fat, that slows gastric emptying and slows peristalsis. So for those people that have constipation as an underlying presenting symptom, it can be quite challenging with this diet. So what I do is I tailor that diet a lot more. And but long-standing constipation also in and of itself can cause what we would term like a large intestinal inertia, where there's just no response from the firing nerve endings and stretch receptors, etc. So there is a little bit of a constipation bowel retraining page. If you go to Sibo test and you go under what is Sibo and click on the constipation link, it will bring you to what I'm going to present now. But what I like, because it actually really helps patient get involved in the treatment plan. So what I usually do is I divide my treatment into oral agents and exercises and stress reduction and what's the last one? I think it's retraining the vagal nerve. So the oral agents would be magnesium, though that's not considered a laxative. It still helps to pull water into the colon, and also as a small intestinal or a smooth muscle relaxant. Also, what I often use is a combination of cascara and a herb called kawa kawa from New Zealand, which is it's not kava, but it has sort of an enteric nervous system relaxation effect. You don't really want prunes because prunes actually contain sorbitol, which is a high FODMAP, so we don't usually use that. But I do adjust the diet to contain some insoluble fiber like brown rice, rice bran, and increased dark leafy vegetables. So that's sometimes a must for people that have constipation. So you definitely need to adjust the diet on a case-by-case diet though trying to really stay within the confines of the diet as much as you can. The exercising and breathing techniques so important to stimulate the diaphragmatic movement. And so often I see people that have very, very high stress or inner tension, and I ask them to breathe or demonstrate how they breathe, and there's just nothing happening in terms of diaphragmatic movement. And all you need to do is ask your patient to put their hand on their belly button and see if the hand goes, you know, up and down. That is not diaphragmatic breathing, that is chest breathing. But if it goes out and in, it's much more of a belly breathing. So in this handout or the site that we have on Sibo Test, it walks you through all of that. But other exercises, walking is a really nice activity because of not just increasing breathing, but obviously anything that gets the body, the blood flow moving will be very helpful. This is just a little wonderful little TED Talk, 5-minute TED Talk by this woman who demonstrates belly exercises, and I often give patients this link because it really is, it works incredible for some people, not for everyone, but for a lot of people. And then many of you are familiar with Dr. Datis Karazian, who is a chiropractor, but also does functional neurology, and he talks about the vagus nerve and the need to exercise the vagus nerve in long-standing digestive issues. And he does that with things like gargling and gagging, which sounds horrible, but it's not that bad, as well as coffee enemas. And there is a YouTube video that I often tell patients to watch, and you can find that on YouTube. The link is also on our website. Other ideas to retrain the sluggish colon is breathing exercises, and especially alternating nostrils in the evening. That's really wonderful way of getting your patient engaged. And another one is, this is one of my favorites. It's called the inner balance device, and it's great for patients that have iPods or iPads. And it's a little device where they have to download an app, and then they clip this little clippy thing onto their ear, and it measures heart rate variability. And it's a real great tool for patients to see if they're in fight or flight or rest and digest, and then it gives them exercise in real time to bring them down into rest and digest. So it's just wonderful, especially if you have a high stress patient and they do it just before meals, and they can get that at heartmath.com. And the meditation, these are just examples that I use. I use Headspace app on iPhones and Chopra meditations, which are like little 15-minute downloadable daily meditations. So really getting them very engaged in activating their rest and digest. And then also just a proper, sometimes this helps it helps incredibly well in patients that have this sort of really sluggish colon and changed anatomy due to long-standing constipation, just to have them squatting. And I mean, old phone books work just as well, but a squatting stool is very helpful. Okay, so again, we really want to help you educate your patients on this condition. Again, just a reminder about the diets, handouts, and protocols that are available on Sibo Test. And also we also have some brochures that you can hand to your patients. They look like this. You can put your stamp on the back and have them in your office, and you can just email Emily if you'd like a stack of these. And it's basically just instructions. You hand this to your patient, and it gives them instruction on how to order the test kit, and that's very helpful. Now, one word about marketing and positioning yourself as a natural SIBO treating expert. We have, this is just a screen grab from our website, Find a Sibo Treating Practitioner. We have a database where you can add your name. If you've ordered 3 test kits through us, you can have a page just for yourself and have patients find you. We're actually #1 Google ranking website for Sibo tests in Australia and for the natural treatment of Sibo. And we have an ever-increasing database, so it's a really good place to put your picture. Here's Emily's smiling face, and so hopefully you can do the same and position yourself in that in this ever-growing market. We also have a Siebel Masterclass coming up for those who need or feel like they really do want to specialize in this and need a little bit more one-on-one. And it's a web-based conference call with me and about 10 to 12 practitioners max, and we will go through about 3 cases every 2 weeks, so we meet fortnightly for 6 weeks. And the small class size really ensures that you get a little bit more one-on-one and you can present your case. And you can sign up for that at Sibo Test. The dates are yet to be announced. So I really want to thank you very, very much for your time this evening. Just a few things that are going to be on the horizon. Dr. Pimentel talked about a new drug coming out that I think this study starts in July. It's not a drug that kills methanogens, but it stops the production of methane, so that'll be interesting. I don't think we will prescribe it as natural practitioners, but it's just something good for you GPs out there to know. And there is, I want to actually look at those antimicrobials that I've mentioned before, the manuka and pomegranate and so forth. And I'm actually thinking, should there actually be a methanogen diet that is a little bit higher in insoluble fiber? So not soluble fiber like chia and flax seeds, but maybe a little bit more higher in your insoluble fibers. And we also need a little bit more research on herbal prokinetics. So these are all the developing areas. And I hope that you can join us for next year's symposium, hopefully in Portland. Now I have about 10 minutes for if any of you, I know some of you have left already, but if any of you have questions, I'd be happy to answer them. If not, then any questions that will come in over the next few minutes, we will also send them around in terms of question and answer time. So I'll thank you very much for your time this evening. Doesn't look like we have any questions, either that or I have a technical malfunction. So what I will do is I will just leave you with this. And yes, thank you so much for your time this evening. Have a good night.
Say how many sign up.